Hi guys, I hope you're well. So welcome back. Today I want to start a new series in CVS pharmacology for the hypertensive medications. Right, so on this slide I've summarized 4 of the main different types of antihypertensive medications that we use in a medical setting. So firstly we have diuretics. I have a whole playlist on diuretics actually in the same folder in the CVS medications. So I suggest you watch that, because in this video I'm not going to go into so much detail, especially like the mechanism of action. I'm not going to go into so much detail on the mechanisms of action of these different types of diuretics. I'll literally just whiz over them because I've covered them in so much detail in my other diuretics video. So examples of diuretics include thiazide diuretics, loop diuretics, and potassium sparing diuretics. So there are other 2 types like the carbonic anhydrase inhibitors and the osmotic diuretics, but those are not commonly used for hypertension. They are useful for their other pharmacological function and properties, not really for hypertension. So I've missed them out in this video. So the next group of antihypertensive meds, we have sympatholytics. So these sympatholytics are basically just drugs that inhibit the sympathetic nervous system. So these sympatholytics are subdivided by their anatomical site of function. For example, some sympatholytics, they act centrally, like clonidine, methyl dopa. So these drugs, they act in the central nervous system. So we also have sympatholytics that act at the level of the ganglion. Some of them, they block simply the alpha adrenergic receptors. Some they just block the beta adrenergic receptors, and some have a combined alpha and beta blocking properties. So the next group of drugs that we commonly use for hypertension are the vasodilators. So there are 3 main mechanisms as to how vasodilators work. So firstly, they can block the calcium channels in the myocardium and in the smooth muscles of arterioles as well. So those drugs, we call them calcium channel blockers. And then the next examples of vasodilators, they act by promoting the release of nitric oxide. So nitric oxide is a vasodilator. Another way that vasodilators act is by opening off the potassium channels, leading to hyperpolarization. So there are some drugs that work on opening the potassium channels and therefore dilating our vessels. And last but not the least, we have our angiotensin antagonists. So we have 3 different subtypes. We have the ACE inhibitors, we have the angiotensin receptor blockers, and last but not the least, we have our renin inhibitors. So I'm gonna go through all of this one by one, and I hope you'd find all of my videos useful. If so, please leave a like, or comment if you have any other questions, and comment if you don't understand anything so I could help you understand it better. Okay, so now let's talk about the different drug strategies in managing hypertension. So as we know, hypertension is because of elevated blood pressure. So these are the 3 main ways in which we could reduce our blood pressure. But before I talk about this, I just want to go over 2 different equations that are really vital for us to always keep in mind when we're talking about hypertension and antihypertensive medications. I know you guys know this, but let's just go over them quickly anyway. So blood pressure is cardiac output times total peripheral resistance, and cardiac output equals heart rate times stroke volume. So cardiac output is the volume of blood pumped by the heart per minute, and that's determined by the stroke volume, which is the volume of blood pumped by the heart per heartbeat, and by the heart rate, which is basically the number of times the heart beats per minute. So to reduce cardiac output, so if we reduce cardiac output, we then reduce blood pressure, right? So how exactly do we reduce our cardiac output? So we can reduce our cardiac output, look at here, by reducing our heart rate and by reducing our stroke volume. So reducing heart rate is basically, slowing down the contractions of the heart so it beats less per minute, and decreasing our stroke volume. And we can achieve that by decreasing the contractility of our myocardium. We could also decrease our blood pressure by decreasing total peripheral resistance. So if you look here, if we decrease total peripheral resistance, we also decrease our blood pressure. So we could decrease our total peripheral resistance by vasodilation. So total peripheral resistance basically just means the resistance of the arteries to the flow of the blood, okay? So the next way we could decrease our blood pressure is by decreasing our blood volume. So I hope you could appreciate that there's a direct correlation between blood volume and blood pressure. Like, in medical dramas, when someone comes in with a serious trauma, like a gunshot wound or like multiple stabs in the chest and the abdomen, and they start bleeding out, the doctors will go, the BP's dropping. So, there is a direct correlation between the volume of blood circulating in our body and our blood pressure. So blood volume is determined by the amount of water and sodium we retain in our body. So we could reduce blood volume by promoting diuresis, which is the excretion of water in the form of urine. Right, so before I move on to the different drug therapies, I just want to discuss one important point, which is the idea there are compensatory mechanisms. So if there is hypertension and we give initial treatment, for example, thiazides or any other diuretics, then we decrease the blood pressure, right? But then there might be compensatory mechanisms that would kick in because our body is not stupid. So the decrease in blood pressure, it will try counteract that decrease in blood pressure by two main mechanisms. So the first one is by increasing sympathetic outflow. So the body would induce reflex tachycardia by increasing the sympathetic activity, and this can be blocked by giving beta blockers, okay? And the other compensatory mechanism might be fluid retention and water retention. So that would lead to edema. And this happens because, again, our kidneys are very, very clever. So they increase renin activity and production, and therefore we retain more water and salt, which would mean that we increase our blood pressure. And this mechanism can be blocked by using diuretics, ACE inhibitors, and even angiotensin receptor blockers. So the management usually begins with thiazides, so with diuretics, or like ACE inhibitors and angiotensin receptor blockers or calcium channel blockers. And if the patient is not responsive to monotherapy, which means just one drug therapy, then the doctors or the cardiologist will try mix and match different cocktails of drugs and add more antihypertensive drugs like beta blockers, for example, or ACE inhibitors if those compensatory mechanisms start to kick in. So the goal is to always try and minimize the adverse effects, obviously, and obviously it's also important to consider drug interactions between all of these antihypertensive medications. Generally, if the systolic blood pressure is higher than 160, or if the diastolic blood pressure is higher than 100, then the patient should ideally be on 2 medications. Okay, so firstly, let's discuss the first group of drugs that we use for hypertension. So these are our diuretics. So as I said at the beginning, I have a whole playlist just talking about medications we use as diuretics. So please check that out. I really highly recommend watching them because in this video, as I said, I'm not going to go over the mechanisms of action in so much detail. So anyway, we have our diuretics. Diuretics, we have a potassium wasting and potassium sparing diuretics. So potassium wasting diuretics mean that these diuretics, they get rid of potassium as well as water. So we have loop diuretics and thiazide diuretics. So these two drugs, they promote diuresis as well as, the wastage or the excretion of potassium. So usually you might need to supplement the patient with potassium just to make sure that their electrolytes are balanced. So with loop diuretics, we have furosemide, torsemide, bumetanide, and ethacrynic acid. So with thiazide diuretics, examples include hydrochlorothiazides, chlorothiazide, and we have our thiazide-like diuretics like chlorthalidone and methalazone. So we also have our potassium-sparing diuretics. So these diuretics, they get rid of water, but then they promote the retention of potassium in our body. That means, you know, they shouldn't, if you're giving this to the patient, they shouldn't be on any potassium supplements, otherwise they would be like hyperkalemic, and that can lead to a multitude of problems like different types of arrhythmias and things. So we have are spironolactone and eplerenone. So these are steroid derivatives. They're actually aldosterone receptor blockers. And we also have triamterene and amiloride. So these work by blocking the sodium channels, sodium epithelial channels in the collecting duct. So these two different groups of drugs are both potassium-sparing diuretics. Okay, so thiazide diuretics. Just to give you general info, they act on the distal convoluted tubule, so this bit of the nephron, just after the ascending loop of Henle. So in this region, we usually reabsorb 5 to 10% of our sodium. Thiazide diuretics are active by the oral route, apart from one, which I'll mention in a bit. So examples include hydrochlorothiazides and chlorothiazide. So chlorothiazide is the only thiazide available for both the parenteral and the oral route. And we have our thiazide-like diuretics. Examples include chlorthalidone and methalazone. So chlorthalidone is longer acting than hydrochlorothiazide. So yeah. Mechanism of action. All of these drugs, they block the sodium chloride co-transporter in the distal convoluted tubule. Okay, so they block, very important, the sodium chloride co-transporter in the distal convoluted tubule. And the effects include moderate diuresis. So these drugs are called medium ceiling diuretics because they get rid of moderate amounts of water. They're not the most potent diuretics, but they are fairly good at getting rid of some water. And they increase calcium reabsorption, so they can actually promote hypercalcemia. So this is a very important point because this is the complete opposite to loop diuretics, which get rid of the calcium, and therefore we get hypocalcemia. Okay, so let's continue discussing thiazide diuretics. So uses, it's actually a first-line antihypertensive treatment. It's one of the best initial treatments for hypertension, if not contraindicated, obviously. It can be used alone or in combination with other antihypertensive drugs. So the next one, treatment of mild to moderate heart failure, obviously to remove the edema. It can also be used for the treatment of calciuria, as I said in the previous slide, because we can take that calcium from the tubule and reabsorb it back into the bloodstream. So it could decrease the concentration of calcium in the urine and therefore treat hypercalciuria. It could also be used for treatment of recurrent calcium stones or just reduce the risk of forming calcium-containing kidney stones. And before I go to this next point, I forgot to put here, it's also used to improve bone density for osteopenic patients, which I think I mentioned from the previous slide. And then this last point here, it's used for diabetes insipidus. It's used to decrease urine output in diabetes insipidus. So you might be thinking, why are we using a diuretic to reduce urine output? So in diabetes insipidus, thiazides have a paradoxical effect. So what is diabetes insipidus? So diabetes insipidus is characterized by the excess water loss, right? So that's called polyuria. And thiazide diuretics would further increase this urine loss initially, but would later promote water and salt reabsorption, which means that we could decrease the urine output in these patients. So now the adverse effects. So we obviously get electrolyte imbalances, we get hyponatremia, we lost some of the sodium into the urine. We get hypochloremia because we're not absorbing that chloride, remember, because we blocked the sodium chloride co-transporter. So sodium and chloride are just lost in the urine, so we don't have them in the body, so we become deficient in those electrolytes. We get hypercalcemia, as I've mentioned like many times, and we get hypokalemia because we lose, the potassium in that collecting duct, and we get alkalosis because we lose the hydrogen ions as well. We also get hyperuricemia. So hyperuricemia is, increased urea basically, and the reason for this is because the thiazides, they actually inhibit the organic anion transporter that transports uric acid from the bloodstream into the tubule. So the uric acid just kind of it just builds up in our body basically, which makes us more likely to get gout or exacerbate gout. Contraindications: we can't use thiazide diuretics if we have impaired or inadequate renal function. Alright, just to add to that, as I said about gout, so this is contraindicated for people with gouty arthritis, for example, and obviously we can't use this if someone is already hypercalcemic, because we're just gonna keep increasing their calcium in the body and we might end up killing them. Alright, so moving on to loop diuretics. Just to give you general information, loop diuretics, they work on the ascending loop of Henle, where 20% of our sodium is usually reabsorbed. So this is the ascending loop of Henle in this diagram. So it works in low renal function. So this is actually the drug of choice for moderate to severe renal failure because they do not alter the glomerular filtration rate, whereas thiazides, if you can remember from a couple of slides prior, those cannot be used for patients with impaired renal function, whereas loop diuretics, very important, it works with patients with low renal function. So they're also rarely used alone for hypertension, and the reason for that is because they trigger compensatory mechanisms, and they're usually mixed with other drugs like beta blockers, and they also have a short duration of action. They're used for hypertension as well if thiazides are inadequate, and they're used especially for hypertensive emergencies due to their fast onset of action. So examples include furosemide, torsemide, bumetanide, and ethacrynic acid. Furosemide has vasodilatory action, specifically venodilation, so that's the dilation of the veins. They do not have a direct vasodilator effect on the arterioles. So if you give furosemide, it may relieve the symptoms of left ventricular failure and pulmonary edema, and it's given as IV, I think. Torsemide is the loop diuretic with the longest half-life. Bumetanide is the most potent loop diuretic, and it has less adverse effects compared to furosemide. Ethacrynic acid, it's highly toxic. I don't think it's used quite commonly. It's ototoxic, and that means it's toxic to the ear and the auditory nerve. So the mechanism of action: these loop diuretics, they block the sodium potassium 2-chloride symporter in the ascending loop of Henle. So pay attention here, guys. This is a different symporter compared to the thiazide diuretics. So thiazide diuretics, if you remember, was the sodium chloride co-transporter. Now in loop diuretics, we are blocking the sodium potassium 2-chloride symporter. And where was I? Oh, prostaglandins. So loop diuretics, they also encourage the production of prostaglandins. So prostaglandins have vasodilatory effect. This means that non-steroidal anti-inflammatory drugs, like for example ibuprofen, would reduce their function because if you can remember, NSAIDs like ibuprofen, they block the production of prostaglandins by inhibiting the COX enzyme. So NSAIDs would basically make them less efficacious. Okay, so effects. As I said, they are high-sealing diuretics, which means that they are very, very good at getting rid of the excess water that we are carrying in our bodies. They are very, very powerful. They're the most powerful, excuse me, the most powerful diuretic, and they decrease calcium reabsorption. They cause hypocalcemia. So this is again in contrast with thiazides that increase calcium reabsorption in the body and causes the opposite, which is hypercalcemia. Once again, guys, I'm not really gonna go over the detailed mechanism of action in this video. If you want to know exactly how loop diuretics work, please watch my loop diuretics video in the diuretics series. Okay, so the major application of loop diuretics is to treat edema. So edema can come in the form of pulmonary edema, for example, both acute and chronic, or ascites, that's the buildup of fluid in the abdomen. It can also be used for treatment of mild to moderate heart failure. Again, in heart failure, we can get some edema as well. It can also used for the treatment of hypercalcemia, because as you know from the previous slide, we talked about this. They cause hypocalcemia because they increase the excretion of calcium into the urine. So they're used for severe hypertension and hypertensive emergencies, again because of their rapid onset of action. Adverse effects include electrolyte imbalances like hyponatremia, so that's low sodium, hypocalcemia, low calcium, hypokalemia, low potassium, and alkalosis due to the loss of hydrogen ions in our urine as well. We could also get hyperuricemia here, similar to thiazide diuretics, through the same mechanism. The loop diuretics can also block the organic anion transporter that transports urea from the blood to the tubule. So if we block that, then we're not getting rid of urea, and therefore it stays in our body and we get hyperuricemia, which might exacerbate conditions like gout. And then we also get acute hypovolemia because this is a very powerful diuretic. It's a high-sealing diuretic, so we're getting rid of lots and lots and lots of water, and therefore we might cause acute hypovolemia if we're not very, very careful. So another adverse effect can include cardiovascular complications, and this is mainly due to the fact that we have electrolyte imbalances. For example, we have hypokalemia. And hypokalemia can trigger arrhythmias. Okay, so we have to be very delicate in the balancing of our ions and electrolytes, especially potassium, because potassium is very important for the heart. And if we have imbalances in potassium levels in our body, then either hypo or hyperkalemia, then we might precipitate various arrhythmias. Ototoxicity. So this just means toxic to the ear or the auditory nerve innervating the ear, the inner ear. This mainly applies to ethacrynic acid. And the reason why ethacrynic acid is toxic to the ear is because ethacrynic acid, a loop diuretic, they block the sodium potassium 2-chloride cotransporter, and we also have those cotransporters not just in the kidneys but also in our inner ear. So yeah, that's why this drug can also affect the inner ear. So contraindications include gouty arthritis, because we get hyperuricemia. Also, don't give this to the patients that are obviously already hypovolemic or hyponatremic, hypocalcemic, hypokalemic, or in patients with metabolic alkalosis. So potassium-sparing diuretics, they work mainly at the level of the collecting duct as well as on the late distal convoluted tubule. So this is the late part of the distal convoluted tubule going to the collecting duct. So at the level of the collecting duct, we reabsorb usually 3 to 5% of our sodium, okay? So potassium-sparing diuretics are low-sealing diuretics, which means that they are not very potent. Certainly not as potent as our thiazide diuretics, which are medium-sealing, or our loop diuretics, which are high-sealing diuretics. So loop is the most potent, diuretic. So with potassium-sparing diuretics, there are two main mechanisms as to how they work. So the agent could either block the sodium channels or block the aldosterone receptors, okay? So the sodium channel blocking agents include amiloride and triamterene. Amiloride is more potent and longer acting than triamterene, okay? And for the aldosterone antagonists, these are steroid derivatives, and they have a longer duration of action compared to the sodium channel blockers. So in this group, we have spironolactone and eplerenone. The mechanism of action, as I've explained just now, we have two main mechanisms. So we could either block the epithelial sodium channels, which means that our sodium is not being reabsorbed and therefore they're excreted. And they're excreted with water, because wherever sodium goes, water follows, okay? And they could also block our aldosterone receptors, and those agents are just called the aldosterone antagonists, okay? So in general, what happens is that we promote diuresis, so potassium-sparing diuretics, they get rid of water, but without the loss of potassium, okay? So that means that these drugs we cannot give to patients who are on potassium supplements, because we might precipitate hyperkalemia, and that could lead to a multitude of other different problems, for example, arrhythmias. Alright guys, so let's wrap up our discussion about potassium-sparing diuretics. As I said in the previous slide, they are low-seating diuretics, so they are not as potent as our thiazides and our loop diuretics. They encourage the preservation of potassium ions, again in contrast with thiazides and loop diuretics that get rid of the potassium ions. So common uses is to treat edema. They're also used in heart failure patients to reduce cardiac remodeling, which may reduce mortality and increase the survival of the patient. They're used in secondary hyperaldosteronism and resistant hypertension. So in patients with that have shown no response with a cocktail of other different antihypertensive medications, then we might use potassium-sparing diuretics to help them. They're also used in patients with polycystic ovarian syndrome because they block androgen receptors, which inhibit steroid synthesis. But I think this only happens with high doses. So amiloride specifically is used to decrease secretions in cystic fibrosis patients when administered in an aerosol form, and they are the drug of choice. Amiloride is a drug of choice for patients with lithium-induced diabetes insipidus because they prevent lithium from getting into the tubule. Adverse effects include hyperkalemia because we preserve the potassium in our bloodstream, therefore we increase the concentration of potassium in our body, leading to hyperkalemia. We also get metabolic acidosis because we're not getting rid of that hydrogen ion, remember? So adverse effects of amiloride specifically, we decrease the calcium and magnesium excretion. And triamterene, it's usually not used due to incomplete absorption of the drug, and it has a cocktail of different side effects that we don't necessarily want, like impairment of glucose tolerance, fructose sensitivity, interstitial nephritis, and renal stone formation. Spironolactone, an adverse effect may include endocrine alterations, for example, gynecomastia in males and menstrual irregularities in females. I think eplerenone, which is the other potassium-sparing diuretic, has less affinity for gonadosteroid hormones, so with that you might not get these side effects so much. So contraindications, obviously if the patient is taking potassium supplements, we don't give this because that would just encourage hyperkalemia even more. Also with patients taking ACE inhibitors and angiotensin receptor blockers. We don't give potassium-sparing diuretics because, again, if you administer potassium-sparing diuretics with ACE inhibitors or ARBs, like losartan, for example, that can cause really, really high blood potassium levels. And again, for any reason, if the patient has high potassium levels in the blood, we don't give potassium-sparing diuretics because, again, that would just lead to more hyperkalemia. And we have to be very delicate with our potassium because potassium, either hyper or hypokalemia, is bad because just think about the heart. That can lead to, different arrhythmias. So we really have to be very careful with our potassium balance in the body. Okay, just to finish off our discussion about the different types of diuretics that we use for hypertension, I have created this table that summarizes the most important information because I know I've just bombarded you with quite a lot of information and there's a lot of information to take in. So I hope this table helps you remember the most important things, okay? So let's start. Thiazides. Examples include hydrochlorothiazides and chlorothiazides, and we have thiazide-like diuretics like chlorthalidone and metalazone. Loop diuretics, we have furosemide, torsemide, bumetanide, and ethacrynic acid. Okay. For potassium-sparing diuretics, we have our sodium channel blockers like amiloride and triamterene, and we have our aldosterone antagonists, including spironolactone and eplerenone. So thiazides work by blocking the sodium chloride cotransporter in the distal convoluted tubule. Okay, the sodium chloride cotransporter in the distal convoluted tubule. That's what thiazides block, and this is where they act. Okay. For loop diuretics, they block the sodium-potassium 2-chloride symporter at the level of the ascending loop of Henle. So they block the sodium-potassium 2-chloride symporter at the level of the ascending loop of Henle. Potassium-sparing diuretics, they block the sodium channels in the collecting duct and they block the aldosterone receptors. Okay. So in terms of efficacy, the most potent ones are the loop diuretics. They are the high ceiling diuretics. And then followed by our thiazides, the medium ceiling diuretics. And then our potassium-sparing diuretics. Okay. So uses of thiazides, it's actually a first-line antihypertensive drug, unless contraindicated. Used for the treatment of mild to moderate heart failure, treatment of hypercalciuria, so high calcium in the urine, okay, and treatment of recurrent calcium stones, or just the prevention of calcium-containing kidney stones, okay. And they are used for patients with osteopenia, okay, because they increase the reabsorption of calcium. They also are also used in diabetes insipidus. They decrease urine output. Remember, they have that paradoxical effect for patients with diabetes insipidus. Loop diuretics are used for severe hypertension and especially hypertensive emergencies, and that's because of the rapid onset of action. They're also used for heart failure and to treat edema because they're really powerful diuretics. They just get rid of the water. So edema, such as in pulmonary edema and ascites. They're also used for the treatment of hypercalcemia, so that's high calcium in the bloodstream, because loop diuretics, they get rid of the calcium in the urine, which is the complete opposite of thiazides, okay? Potassium-sparing diuretics, so they are used for resistant hypertension, usually in combination with thiazides, okay? They have a synergistic effect. So they're also used for heart failure and treatment of edema, secondary hyperaldosteronism, polycystic ovarian syndrome, and amiloride specifically is used for cystic fibrosis patients as an aerosol to decrease the secretions, and in lithium-induced diabetes insipidus. So the electrolyte imbalances. Thiazides create hypokalemia, hyponatremia, metabolic alkalosis, hyperuricemia, so that's high uric acid in the body, and hypercalcemia. So loop diuretics, they also create hypokalemia, hyponatremia, metabolic acidosis, and hyperuricemia. So if you notice, the first four are the same, okay? The only difference is thiazides, they create hypercalcemia, whereas loop diuretics, they create hypocalcemia, okay? The potassium sparing diuretics, they create hyperkalemia, hyponatremia, and metabolic acidosis. So that's important to remember, because the loop and the thiazides, they create metabolic alkalosis, whereas the potassium sparing diuretics, they create metabolic acidosis.